lens is designed is very clever, being an inverted meniscus implant, and in so doing, it can also it improves peripheral vision, but also by increasing negative spherical aberration, there's a provision of increased range of focus. Now, just a quick word about terminology. It's a bugbear of ours at ACOS. Where people keep talking about EDOF, and I think that's the most confusing term I've ever heard, because they mix up terminology with the concept with mechanisms of action, and I think you need to differentiate the two. Apart from anything else, EDOF, the standard to meet EDOF is only 50%. 50% of patients require intermediate vision to meet the criteria of EDOF. And my question is, what do you do with the other 50%? I can't really say something's reliable at the same rate as tossing a coin. So what we at ACOS did was look at the nomenclature, and we divided it up into different components. But our standard is 80% must have distance intermediate corrected visual acuity of 0.2 rather than 50%. And I think that's a much better bar to follow. So lens performance really is a range of focus, which we've been talking about, an increased range of focus. And there's a mechanism of action which Pablo has elegantly talked about with regards to inverted meniscus and the increased spherical aberration. And then there's the issue of dysphotopsis, which comes about from the mechanism of action. And very nice that we have a lens that actually does not cause any dysphotopsis at all. So basically, we've got these categories of lenses. A monofocal, somewhere in between increased range of focus and monofocal will be a monofocal plus. And then you've got the full range of focus. So our experience, well, we commenced by doing the 40-70 as recommended by Pablo et al. and his co-workers. And we did 8 patients bilaterally. The mean age was 69. These are all patients with cataracts, equivalent between males and females. And later on, we thought, well, if you're getting more range of focus with the 70, why don't we just try 70-70? And we did 5 patients bilaterally, and we have a few more lined up now. But I wanted to test the water to see how they did before going out and go all guns blazing. And you see this was a slightly older age group. And so talking about implantation, the lenses can be quite sticky, and there are a few little tricks that are useful to articulate. This is the lens we put in. I like to have the lens unfold inside the bag. So I put the haptics in underneath the ledge there of the Medicel cartridge. But on top, I will use HPMC quite liberally to try and avoid sticking. I push the lens forward, but I pull back to make sure I don't grab the distal haptic, and I don't waste any time in injecting the lens into the eye, because the more time you take, the more it wants to stick to the optic. The great thing about the sticky lens is it sticks to the capsule, and we haven't had any patients yet who have had to have a YAG capsulotomy. They're all have nice clear capsules with an adherent IOL, which is posteriorly vaulted onto the capsule. So that's another thing that's not been discussed, but it's been our observation. I don't know if Volta or Miguel have found the same thing. So looking at these patients, because we've got different lenses in different eyes, we have to look at each one independently. So the dominant eye had the ART 40, and the non-dominant eye, the ART 70. And looking at the refractive outcomes, then we aim for micro monovision as well. And you'll see the non-dominant eye outcomes were about minus 0.8 mean compared to minus 0.3 mean in the dominant eye. Cylinder was low in all. And those that had astigmatism, we did limbo relaxing incisions with a femtosecond laser. So here we're looking at this is the attempted versus achieved, and the 2 different groups, and you'll see that they're exactly the same in terms of outcomes, absolutely identical. I had to look at this data twice to figure it out. But in terms of attempted versus achieved, remember we were attempting myopia in the ART 70 group and emetropia in the ART 40 group. Looking at the dominant eye and the non-dominant eye, you can see the visual outcome, the refractive outcomes were within a diopter there. Uncorrected distance visual acuity. Now this is binocular. Patients, they neuroadapt with both eyes open. They don't neuroadapt with one eye at a time. So we always find that the binocular vision is better. But what's really impressive is how much better they are with the ART IOL. And you can see that right here. There's 88% are seeing 6.6 binocularly, Whereas if you look at the monocularly, it's only 63% with Art 40 and 50% with a myopic with the Art 70. But combined, they seem to do a lot better. And quite considerably too. And same with the 60. Now we don't measure at 67 centimeters, we measure at 60. A long time ago when we were using the crystal lens, the accommodative implant, I went around with a tape measure to see what the distances were. And the laptop is about 60, a dashboard in the car is 80. So that's what we used, and we've been using that ever since with our software as well. And these are the outcomes here. So if you're looking at 0.2 logMAR, which is the same as 2032, well, 100% get it. And they do monocularly with the Art 40, and they certainly do with the Art 70. So again, we've more than met the EDOF standard. We've actually more than met the ACOS standard for increased range of focus. This 80 centimeters does even better than 60. And 40 centimeters, this was quite a surprise. So we had patients who were fairly independent of glasses. They'd only have to use a pair of glasses in very dim light, and 80% were 20/25, 88% 20/25 or better, and meeting the 0.2 logMAR scale, 100% got that level at 20/30. And you can see that this is quite impressive here. This is 20/30, 100% got that in the ArtIOL group. And for some reason, the Art 70 didn't do as well, but these were 1 month data. And I have seen patients since, and they seem to do better. I think they take longer to neuroadapt with the Art 70. So this is the summary of those results. And you can see that Art 40 seemed to do very well at all distances. The Art 70 at distance, well, they were myopic, so they didn't do as well. Did very well intermediate. And for some reason, at 40 centimeters, they didn't do so well. But binocularly, they did well at all distances. Looking at defocus, this is an example of a patient. This is the dominant eye, the non-dominant eye, and the cumulative binocular defocus. And this is the 0.2 logMAR level. Looking at contrast, and this is the pre-op and post-op. And this is the Art 40 and the Art 70. So the monocular data did not look good, and the non-dominant did not perform as well as the dominant. Well, that's to be expected because of the myopic shift by intention, and also the implant. But we thought we'd just go ahead and use the Art 70 in both eyes. I know patients like to be able to read, so here we want to push them. So we did 5 patients bilaterally, and we aim for plus 0.25 to plus 0.5 in the dominant eye and plano in the non-dominant eye, with the understanding that the lens just shifts towards myopia anyway. And these are outcomes. We had one outlier here, which was a bit of a refractive surprise. The lens didn't sit as posteriorly as we'd expected. And this is the same patient here in both eyes. She did the same thing. So that's kind of skews our data, but that's okay. I've included them all here. And these are the outcomes. Preoperatively, they were hyperopic. Postoperatively, minus 0.44 diopters. This is the overall group. Uncorrected distance visual acuity, this is the dominant eye and the non-dominant eye. And you'll see that the non-dominant eye was a bit myopic, and you can see that the distance vision was not as good as the dominant eye. But binocularly, binocularly here, you can see the cumulative 80%, we're seeing 6.6 or better. So it's quite interesting how monocularly they don't seem to do so well, but the 2 eyes together do very, very well. And I think a lot of it's to do with neuroadaptation, which is what we naturally do when both eyes open. At 60 centimeters, they again, 100% got the increased range of focus standard from ACOS, and they certainly did binocularly. Again, 80 centimeters, extremely good outcomes, 100% seeing 6.6. And at 40 centimeters, this is what we really want to know about on patients. This is the dominant eye, the non-dominant eye. So you can see the myopic shift certainly helps. This is the logMAR 0.2 or 20/30. And this is a monocular uncorrected near visual acuity in the overall group. And then this is binocularly, looking at the binocularly, 100% get 6.9 or better, 80% 6 over 7.5, and 60% 6.6. This is the defocus curve on the 70/70, the dominant eye, the non-dominant eye with the shift, the myopic shift, and cumulative binocular contrast sensitivity, again, pre-op and post-op. It's not quite clear why they seem to do slightly worse post-op with 3 to 6 cycles. But I think a lot of that was also back to neuroadaptation. It's worth looking at those patients again in a few months' time. So this is the summary again. At distance, they didn't seem to do so well, which is consistent with what we found with the other with the 40-70. Intermediate did very well, and near they did extremely well binocularly. This is one patient that had both lenses were 0.7 millimeters more anterior than predicted, both eyes, and that's why she was a bit myopic after surgery. So in conclusion, the ARTS 40-70 combination seemed to do better at 6 weeks than the ART 70-70. I think the ART 70-70 needs a bit more time for adaptation, and again, we need to check that out in time to come. Certainly, what we see in terms of results and what the patients tell us, I can tell you that the group, the ART 70-70 group, are way, way more happier than the ART 40-70. We're doing patient-reported outcome measures independently. It'll be interesting to see what the combination does with these patients and what they report at the 3-month mark when they're asked to review. So binocularly, they do very, very well. And there's this summation of peripheral good focus and the range of focus, and a few unanswered questions. Maybe public can enlighten us a little bit. But certainly there have been no dysphotopsias, and all patients except one, the one that had a myopic surprise, was spectacle-free. So thank you for your attention and for including me in this seminar.